Hello and welcome to today's webinar, Living Well with Celiac Disease and Diabetes, hosted by the National Celiac Association and the Harvard Medical School Celiac Research Program. The Harvard Medical School Research Program was founded in 2013 by celiac experts in 3 Boston hospitals, Dr. Alan Leichner at Boston Children's, Dr. Ciarán Kelly at Beth Israel Deaconess, and Dr. Alessio Fasano at Massachusetts General Hospital. The highly collaborative Harvard Medical School program has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. I'm Lee Graham, Executive Director of the National Celiac Association, celebrating our 30th year serving the gluten-free community. National Celiac provides educational resources on our website like Ask the Dietitian, Raising Our Celiac Kids, and Supporting Our Celiac Seniors. Zoom interactive meetings are open to all on the second Tuesday of every month. And my thanks to all of you who have continued to support our food insecurity initiative, Feeding Gluten-Free. Thanks to you, we are now delivering gluten-free food to food pantries in over 3,000 communities across the United States. For today, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. Closed caption is available by clicking the CC button. For those of you who have registered for continuing education units, please fill out the survey that will be added to the chat during the webinar. If you are still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org or by phone 857-282-6470. Also, this session is being recorded and will be available for viewing on National Celiac's website, nationalceliac.org. Our moderator today is Dr. Ciarán Kelly. Dr. Kelly is professor of medicine at Harvard Medical School and director of gastroenterology training at Beth Israel Deaconess Medical Center in Boston. He also leads research programs on the causes of celiac disease, its diagnosis, and new approaches to treatment. Dr. Kelly is the author of more than 200 clinical and basic research publications appearing in medical and scientific journals, including Gastroenterology, Vaccine, Infection, and Immunity, the Journal of Clinical Investigation in the Lancet, and the New England Journal of Medicine. Welcome, Dr. Kelly.
Lee, thank you for that welcome and introduction. Welcome to everybody who is joining our webinar on celiac disease and diabetes mellitus. To just reiterate a little of what Lee mentioned, there's a Q&A feature through the Zoom that you can use to ask questions. The session is being recorded and it can be viewed later on the NCA website, as well as the website of the Harvard Medical School Celiac Research Program. And I want to thank the National Celiac Association for co-hosting this webinar with us. And importantly, for those who are seeking continuing education units, these are available for dietitians, nurses, physicians, and social workers if you've pre-registered for the webinar. To receive your continuing education units, please fill out the survey that will be posted in the chat session during the webinar. And now it gives me pleasure to introduce our first speaker, Dr. Caitlin Colling. Dr. Colling is an adult gastroenterologist at Massachusetts General Hospital and an instructor at Harvard Medical School. She received her medical degree from the Perelman School of Medicine at the University of Pennsylvania and is board certified in endocrinology, diabetes, and metabolism, as well as in internal medicine. Her diverse publications include research into aging, obesity, overweight, anorexia nervosa, and the use of evidence-based cardiovascular preventative therapies in patients with type 2 diabetes and with atherosclerotic cardiovascular disease. Her clinical practice focuses on the care of patients with type 1 and type 2 diabetes mellitus, and she has an interest in the care of patients with both diabetes and celiac disease. So Caitlin, I'd like to ask you to share your screen and share your presentation with us.
Thank you very much for that kind introduction. I'm very excited to be here with you all today to discuss these two very important and challenging chronic conditions, celiac disease and type 1 diabetes, challenges in diabetes management in adults. I hope to add the perspective of caring for the adult with both these conditions, and the group of us speaking today will highlight the need for really a team-based approach to managing these two chronic conditions. I have no disclosures. Today, we'll be focusing on screening for celiac disease in adults with type 1 diabetes, screening for type 1 diabetes in adults with celiac disease, and then the management of type 1 diabetes in adults with both conditions, celiac disease and type 1 diabetes. But first, let's take a step back and talk about why we're discussing these conditions together. We know that celiac disease and type 1 diabetes are associated. Both are autoimmune conditions, and the development of both celiac disease and type 1 diabetes involves genetic susceptibility, exposure to an environmental antigen or molecule, and then presentation of an antigen to the immune system. As everyone here is very familiar, celiac disease is an immune-mediated enteropathy triggered by dietary gluten, while type 1 diabetes is characterized by antibody-mediated destruction of the beta cells in the pancreas, resulting in inadequate insulin production and hyperglycemia. Historically, the focus on the overlap of these two conditions has really been on the shared genetics and the shared genetics risk factors, specifically the high-risk human lymphocyte antigen genotypes, or HLA. It's estimated that about 50% of the genetic risk for both disorders is due to the HLA class 2 antigen-presenting molecules. But we also know that these high-risk HLA genes for both celiac disease and type 1 diabetes are relatively common in the general population, and that the majority of the individuals who are expressing these genes will never develop either celiac disease or type 1 diabetes, which has really highlighted that beyond shared genetics, there are other factors that are contributing to the development of the diseases. And more recent study has focused on environmental or non-genetic factors that play a role in the development of these conditions, as highlighted here by the environment bubble and the immune dysregulation bubble. Environmental factors that have been investigated include infectious diseases such as viruses, the gut microbiome, and infant feeding. And it's known that immune dysregulation contributes to both the development of both conditions. I think it's also important, and what this figure is highlighting, is that despite shared risk factors, some individuals will develop only celiac disease, others will develop only type 1 diabetes, some will develop both conditions, and many develop none. And it's unknown at this time why that is. But it is known that the prevalence of celiac disease is higher in patients with type 1 diabetes than the general population. It's estimated that about 5% of individuals with type 1 diabetes have celiac disease, and this is about 4 to 6 times greater than that in the general population. The incidence of both conditions is increasing, which is further evidence for a role of environmental or non-genetic factors in the development of these conditions. So now we're going to turn to screening for celiac disease in adults with type 1 diabetes. The American Diabetes Association recommends that adults with type 1 diabetes be screened for celiac disease only in the presence of gastrointestinal symptoms, signs, or laboratory manifestations that are suggestive of celiac disease. Suggestive symptoms can include diarrhea, malabsorption, or abdominal pain, and signs can include weak bones or osteoporosis, vitamin deficiencies, and iron deficiency anemia. It has been demonstrated that in adults with type 1 diabetes, they may have a transient or temporary elevation in celiac disease autoantibodies. So if the tissue transglutaminase IgA, which is the screening blood test for celiac disease, is only mildly elevated, a confirmatory small intestinal biopsy is recommended before therapy or a gluten-free diet is initiated. And the small intestinal biopsy remains the gold standard for the diagnosis of this condition, as we all are familiar. We're now going to spend a moment just briefly talking about a case of a 45-year-old woman who had type 1 diabetes. She was diagnosed with the type 1 diabetes at age 25 with a hemoglobin A1C of 9.6%. Any value of 6.5% or higher is diagnostic of diabetes. In the past, she had been followed with endocrinology, but due to work commitments and a busy schedule, she hadn't been seen for several years, and her primary care provider had been managing her prescriptions. And in this time, she had noted increased bloating, but she thought this might be related to diabetic gastroparesis, which is slowed emptying of the stomach and can be a complication of diabetes. So when she reestablished care with endocrinology, screening labs were sent for both thyroid function and celiac disease. And the celiac disease test was sent in the setting of her symptoms. The thyroid function tests were normal, but the tissue transglutaminase antibody IgA was significantly elevated, and the diagnosis of celiac disease was confirmed on duodenal biopsy, and she was started on a gluten-free diet. This case really raises the question of how common is this individual's story? And we know that the diagnosis of celiac disease is often delayed. And how is this different in patients with type 1 diabetes? A study of about 120 patients with type 1 diabetes and celiac disease that was performed in the Netherlands looked into this question. And they found that about 1/3 of patients with type 1 with both conditions had reported celiac disease symptoms for at least 5 years prior to diagnosis. The percent of patients who have symptoms for at least 5 years is even higher for patients who are diagnosed with the celiac disease as adults, with nearly 50% having symptoms for at least 5 years. This study also demonstrated that many individuals are diagnosed with celiac disease without any celiac disease-related complaints. And in this study, about 30% of patients were diagnosed without any celiac disease symptoms. Most patients are diagnosed with celiac disease after the diagnosis of type 1 diabetes. In this study, it was about 92%. And the timing of diagnosis of celiac disease can be much later after the diagnosis of type 1 diabetes, with about 40% of patients diagnosed with celiac disease at least 10 years after the onset of type 1 diabetes in this study. What we're looking at here in this slide is the timing of the diagnosis of celiac disease in the black bars and type 1 diabetes in the white bars in this study. And this figure really highlights that these conditions can be diagnosed throughout the age spectrum. So at a young age, but also up into patients' 70s and 80s. We do see that type 1 diabetes is diagnosed at a younger age, and this study identified 2 peaks on the diagnosis of celiac disease at age 10 years and 45 years. So we're now going to transition to speaking about screening for type 1 diabetes in adults with celiac disease. But first, we'll be distinguishing between type 1 and type 2 diabetes. Because we're talking about the adult population, type 2 diabetes is a much more common form of diabetes. About 90% of adults with diabetes mellitus have type 2 diabetes. Both conditions are diagnosed by the presence of high blood sugars, and as chronic conditions, they can damage many organ systems due to if the blood sugars are persistently elevated and inadequately controlled. Comparing type 1 and type 2 diabetes, as we know, type 1 diabetes is an autoimmune disease which results in the loss of insulin production. Type 2 diabetes, the high blood sugars result from the body being unable to produce enough insulin, or the insulin not functioning properly, so that high blood sugars develop. And this is called insulin resistance. Risk factors also vary between the 2 conditions. Risk factors for type 1 diabetes include family history, genetics, and geography, whereas risk factors for type 2 diabetes include family history, but also ethnic background, age, and overweight, obesity. Type 1 diabetes is often diagnosed in the presence of symptoms, while type 2 diabetes is more often diagnosed by screening, as symptoms may appear more slowly. And the treatment of the conditions, while there is some overlap, differ, as type 1 diabetes treatment requires insulin administration. Type 2 diabetes treatment may involve insulin, but it can involve other medications and exercise and diet. And for the remainder of the talk, we are going to be focusing on type 1 diabetes because of its relationship with Celiac Disease Association. And as noted, type 1 diabetes is a cellular-mediated autoimmune destruction, and it results in loss of the insulin-producing pancreatic beta cell and is characterized by insulin deficiency. Insulin is a hormone in our body that regulates the amount of sugar or glucose in the blood, and it signals to our cells to use sugar. We do know that the rate of beta cell destruction is variable in individuals who are developing type 1 diabetes, but when the body can no longer produce sufficient insulin, high blood sugar or hyperglycemia develops. The self-antigen responsible for activating the autoimmune response in type 1 diabetes is not currently known. And at the time of diagnosis, testing is performed for multiple autoantibodies that are markers of beta cell autoimmunity. So discussing screening for type 1 diabetes in patients with celiac disease. As mentioned about 2 slides ago, patients with type 1 diabetes often present with symptoms. These can include excessive thirst, urination, fatigue, weight loss, and vision changes. And they have often markedly elevated blood sugar levels, and it's actually life-threatening, the insulin deficiency. As a result of the severe and acute presentation of type 1 diabetes, there's no specific screening for type 1 diabetes recommended in patients with celiac disease. But it is recommended that individuals with celiac disease are familiar with the symptoms of diabetes in case they were to develop them. Switching our focus to discuss the management of type 1 diabetes in adults with celiac disease and type 1 diabetes, the treatment of type 1 diabetes is it's essential that insulin is involved. So this is individuals with type 1 diabetes have an absolute deficiency of insulin, and what we do when we treat type 1 diabetes is replace that hormonal deficiency. Insulin can be administered with multiple daily subcutaneous injections or a continuous insulin infusion or insulin pump. And the dose of the insulin is matched to the meal eaten, specifically the carbohydrate in the meal. As a result, nutrition therapy plays a very important role in the overall diabetes management, and is helpful and actually critical to achieving the goals of diabetes management, which is to keep the blood sugar levels as close as normal as possible to delay or prevent complications. So all of the teams that are treating type 1 diabetes are really focused on the long-term health of the individuals and preventing complications. The main complications of type 1 diabetes include problems with the eye or retinopathy, nerve damage, which is neuropathy, heart attack and stroke with cardiovascular disease, and kidney problems, also known as nephropathy. And many trials have shown, and studies have shown, that dietary interventions and insulin therapy achieving tight glycemic control or blood sugar levels close to the normal values can prevent these complications. As diet is a very important part of type 1 diabetes management, it is recommended that individuals who are diagnosed with type 1 diabetes have diabetes-focused medical nutrition therapy at diagnosis and as needed throughout life. And this is very important because there is no single diabetes diet, and it really is a goal of treating diabetes for everyone to find an individualized diet plan that works for them. The American Diabetes Association does not provide specific total dietary compositional targets, but really focuses on tailoring the approach to the individual. And Sharon Weston will be discussing that a bit later. The treatment of type 1 diabetes in adults with celiac disease has been studied in very few studies overall, but those studies that have been focusing on the effect of celiac disease on blood sugar control have had some inconsistent results, with some studies finding improvement, others finding deterioration, and others finding no effect when individuals who have type 1 diabetes and celiac disease follow a gluten-free diet. One study that looked at individuals with type 1 diabetes who were newly diagnosed with celiac disease found that the adults who had both conditions had a higher prevalence of advanced kidney disease and eye disease and worse glycemic control. This study followed those individuals for 1 year of a gluten-free diet and found that there was no difference in the quality of life scores between individuals with and without celiac disease. But overall, there's very little study with adults with both these conditions, and further study is needed to understand if following a gluten-free diet for individuals with celiac disease and type 1 diabetes can prevent the complications of type 1 diabetes. In terms of the treatment of celiac disease in individuals with both celiac disease and type 1 diabetes, gluten-free diet is the only treatment for celiac disease, and so the recommendation for this diet is the same for patients with or without type 1 diabetes. But as everyone here knows, the gluten-free diet can be socially and economically complicated, and when this is added on to the dietary restrictions associated with type 1 diabetes, it can be very challenging and can result in poor compliance. It's estimated that between 25 and 75% of individuals are unable to follow the gluten-free diet when they have both conditions. Returning to the case of the 45-year-old woman, so after the diagnosis of celiac disease and initiation of gluten-free diet, her symptoms improved. She did follow closely with a registered dietitian nutritionist and developed an individualized dietary plan for the management of both conditions. But she reported that she had felt increasingly socially isolated and struggled going to restaurants. She did join a support group through the National Celiac Celiac Association and found others with both diagnoses and found this helpful and gained more comfort with managing both conditions. Her story highlights the impact of an individual's life when they're carrying not just one, but two chronic conditions. This has been looked at in limited studies. One study that looked at about 60 individuals, adults who had both type 1 diabetes and celiac disease, found that women with both conditions had lower social functioning and general health perception than men with both conditions, but that all individuals with both type 1 diabetes and celiac disease overall reported greater social and diabetes-related worry than individuals with type 1 diabetes alone. And this study really highlights that individuals with both type 1 diabetes and celiac disease report a compromised quality of life. And as a clinician, that highlights to me the importance of supporting patients and really a team-based approach to the management of both conditions. So in summary, type 1 diabetes and celiac disease are associated autoimmune conditions. In adults with type 1 diabetes, screening for celiac disease is recommended only in the presence of signs or symptoms. A gluten-free diet can make the management of type 1 diabetes challenging, and close collaboration with registered dietitian nutritionist is recommended. And really more research is needed on the experience and clinical outcomes in adults with both of these conditions. And I'd like to thank you all for your time, and I look forward to your questions.
Thank you, Dr. Colling, for an excellent and very clear presentation. We appreciate it. Our next speaker is Dr. Janaki Vakharia. Dr. Vakharia is a combined adult and pediatric endocrinologist at Massachusetts General Hospital and Massachusetts General Hospital for Children. Dr. Vakharia obtained her medical degree from the Jacobs School of Medicine and Biomedical Sciences in Buffalo, where she graduated cum laude with research distinction. Her clinical and research interests are focused on improving healthcare delivery for young adults with chronic endocrine conditions as they transition to the adult healthcare setting, and understanding the gaps in endocrine providers' knowledge and resources for caring for complex young adult patients. Dr. Vakharia has experience with designing a novel care model for young adults with diabetes that focuses on patients' diabetes care, mental health, and overall well-being as they transition to the adult care setting. And she hopes to create a similar model for young adults with other chronic endocrine conditions. So Dr. Vakharia, I invite you to share your screen and share your presentation with us.
Wonderful. Thank you so much, Dr. Kelly, for that introduction, and to Dr. Colling for setting the grounds with an excellent presentation. So as Dr. Kelly mentioned, I will be presenting living well with celiac disease and type 1 diabetes, but from the pediatric and adolescent perspective. I have no disclosures. So as Dr. Colling had already mentioned, a person with type 1 diabetes is 5 to 7 times more likely to have celiac disease than a person without type 1 diabetes. And the prevalence of celiac disease within the general population, as you may know, is about 1%. But really amongst adults and children with type 1 diabetes, the prevalence of celiac disease has been reported to be about 6% by the Type 1 Diabetes Exchange, with national and other global studies reporting the prevalence of celiac disease in individuals with type 1 diabetes to be anywhere from 4 to 11%. And so given that the co-occurrence of type 1 diabetes and celiac disease is not uncommon, it is important for providers and caretakers to understand the presentation of celiac disease in children with type 1 diabetes, screening and diagnosis of celiac disease in children with type 1 diabetes, the unique aspects of managing both conditions, and the experience of living with celiac disease and type 1 diabetes amongst children and their families. We'll begin with the case of one of my patients who's a 10-year-old boy with type 1 diabetes mellitus. He was diagnosed with diabetes at the age of 9 years in the setting of a 4-pound weight loss over the course of 1 month, excessive urination and thirst. His hemoglobin A1C at the time of diagnosis was 14.3%. Any hemoglobin A1C value greater than 6.5% is diagnostic of diabetes. At that time of diagnosis, he had normal thyroid function, and celiac disease screening was actually not performed at the time of type 1 diabetes diagnosis. We see here his growth chart of his weight, and at the time he was diagnosed with diabetes, you can see that his weight has fallen from baseline down to the 15th percentile. However, within 2 months of his diagnosis of diabetes and initiation of insulin therapy, he was able to gain 6 pounds, and his weight percentile improved to the 25th percentile. However, in the 3 months later, despite continuing with insulin therapy and managing his diabetes appropriately, his weight dropped again down to the 12th percentile. And at this time, his parents had expressed concerns regarding the progressive weight loss and were initially thought that it was related to the fact that he was a picky eater. Over the subsequent months, despite efforts to increase this child's calorie intake, he was not able to gain weight. In fact, he continued to lose weight, and his weight percentile had dropped to the 9th percentile. During this time, though, he had no other symptoms. He had no abdominal pain, nausea, vomiting, fatigue, or headache. We also noticed that during this time course, in addition to the failure to gain weight, his height during this time also started to plateau. So he was ultimately screened for celiac disease at this time, and his celiac disease autoantibodies were positive. He had an upper GI endoscopy performed with pathology showing duodenal mucosa with total villus atrophy. And these findings were confirmatory for the diagnosis of celiac disease. He was then started on a gluten-free diet. Over the subsequent months on the gluten-free diet, we see that his weight actually improved. And by 1 year on the gluten-free diet, his weight was at the 30th percentile. His height also improved after initiation of the gluten-free diet, as you can see here, over the subsequent months. And by the time he was 1 year on the gluten-free diet, his height was at the 28th percentile. During the time course, sort of before and after his celiac disease diagnosis, we noticed that there was some different changes to his blood glucose patterns, as well as his hemoglobin A1C. As you can see here, before his gluten-free diet was initiated, he this is a review of his continuous glucose monitor. And his time in range for normal blood sugar at the time before gluten-free diet was initiated was 29%. What we'll notice, though, is that his glycemic variability, meaning how variable his numbers were in terms of lows and highs, was quite variable. His hemoglobin A1C at the time of celiac disease diagnosis was 8.9%. Interestingly, after he was started on the gluten-free diet, we noticed that his time in range for normal blood sugar was actually lower. However, his glycemic variability overall had significantly improved. And you can just see graphically here that before the gluten-free diet, there was a lot more sort of variation and ups and downs in his overall blood sugars. Whereas after the gluten-free diet was initiated, he had less glycemic variability. And not surprisingly, because his time in range actually decreased after starting the gluten-free diet, his hemoglobin A1C also increased to 9.5% 3 months after starting the gluten-free diet. So growth failure and glycemic variability are just some ways that children with type 1 diabetes and celiac disease may present. But in general, the clinical presentation of celiac disease in children who have type 1 diabetes can be quite variable. And some symptoms that the children may present with are those that are typical of your classic celiac disease symptoms. These include signs such as malabsorption or malnutrition, which can be indicated by vitamin deficiencies or iron deficiency anemia. Children can have failure to thrive or short stature. And then also the classic gastrointestinal symptoms such as diarrhea, poor appetite, constipation, vomiting, and abdominal distension may be present. However, other signs that children with type 1 diabetes may present with include signs related to the impact celiac disease has on their diabetes. And in children with celiac disease and type 1 diabetes, we may actually see a reduction in their insulin requirements prior to starting a gluten-free diet. We also may see an increased risk of symptomatic hypoglycemia, glycemic variability, as we saw in the case. But it should be pointed out that the gastrointestinal symptoms that are typical of celiac disease rarely occur actually in the pediatric patients, specifically pediatric patients with type 1 diabetes. And many children who have celiac disease and type 1 diabetes will actually be asymptomatic or only present with very mild symptoms. And so given the lack of symptoms, it can actually be quite challenging to diagnose celiac disease in children who have type 1 diabetes. But fortunately, we know from studies like this 6-year longitudinal study that was published in 2002 that celiac disease is most likely to occur within the first 5 years of diabetes onset in children. In this study, they followed children at the time of they were diagnosed with type 1 diabetes and screened them with the celiac disease autoantibodies. And what they found was that the antibodies, as well as confirmatory diagnosis of celiac disease by biopsy, was more likely to occur within the first 5 years from their diabetes onset, which was notable to help basically inform screening guidelines for celiac disease in youth with type 1 diabetes. So currently, the American Diabetes Association screening guidelines for children and adolescents recommends screening with celiac disease autoantibodies, also called anti-endomysium antibodies. And it recommends that the screening occur at the time of or soon after diagnosis of the child with type 1 diabetes, but then again at 2 years and 5 years from diabetes onset. Of course, you would want to screen sooner if there were any clinical symptoms present that indicated screening. And interestingly, there's insufficient data to really determine the optimal screening frequency beyond 5 years of type 1 diabetes onset in the pediatric population. As with adults, if a patient is found to have a positive screening antibody for celiac disease, the diagnosis should be confirmed with a small bowel biopsy. And this is particularly important because children with type 1 diabetes have been reported to have elevated celiac antibodies, but without actually having the intestinal clinical diagnosis of celiac disease on biopsy. So after the diagnosis, a patient that has been started on a gluten-free diet may experience certain various effects of the gluten-free diet on their type 1 diabetes. Some very clear benefits that have been reported is that in children who had GI symptoms, growth issues, or hypoglycemic episodes prior to starting the gluten-free diet will likely have improvement or resolution of these issues once started on a gluten-free diet. However, some other benefits or effects of gluten-free diet have been sort of debated in the literature, with some studies suggesting that glycemic control can actually improve, worsen, or actually change, have no change at all upon starting a gluten-free diet. Insulin requirements may also change after starting a gluten-free diet, and typically they go up. And this is related to several factors, including the fact that there's better absorption of carbohydrates after starting a gluten-free diet, which will in turn increase insulin requirements. There's weight gain that occurs after starting a gluten-free diet in those who had previous growth failure. And gluten-free foods, as Sharon will probably talk about next, can actually have a higher glycemic index than non-gluten-free foods, all of which can contribute to the increased necessity of insulin. Although there are some clear benefits of treating celiac disease and type 1 diabetes, we do need to be aware of the impact of living with both conditions has on children and their families, in particular related to the gluten-free diet adherence, daily functioning, quality of life, and parents' perception of their children who have both conditions. We know from studies in children with celiac disease who do or do not have diabetes that adherence in gluten-free diet is better in younger children. It's better in children who have good family and social relationships, as well as in children who where the school environment has really done a great job in integrating celiac disease-related issues into the school. Unfortunately, we know that adherence is worse in adolescents, and there are many factors related to this. Namely, parental supervision is often decreased during adolescence. The adolescents are more independent in doing activities on their own, which can contribute to the lack of adherence. There is additional pressures of peer pressure and the feeling of being different from others that influence this. Additionally, as I mentioned, many children who have celiac disease are actually asymptomatic when eating gluten. And this is a particularly notable point in adherence, because those who are likely to be asymptomatic from eating gluten will often have less adherence. Barriers to gluten-free diet adherence also differs between children who have type 1 diabetes and celiac disease versus those who have celiac disease only. And children who have both conditions report more significant barriers to eating gluten-free at home and in the restaurant environment compared to those with gluten-free only, with the celiac disease only. And some of the major barriers that were reported in studies included the cost of gluten-free food, both the groceries cost to bring food home, but also the cost of gluten-free food in the restaurant environment, the taste of gluten-free food, and then interestingly, social pressures as well, where children with type 1 diabetes and celiac disease felt that the social pressure to not eat gluten-free in the home environment and restaurants was higher than in children who had celiac disease alone. The perceived effects of gluten-free diet on daily life also differ between children who have both conditions versus just celiac disease. And children with both conditions, type 1 diabetes and celiac disease, reported a significantly less positive effect on their overall health and a significantly greater negative effect on activities from adhering to a gluten-free diet, whereas children with celiac disease alone were more likely to report positive effects of the gluten-free diet on all aspects of their life. In terms of the impact of having both diabetes and gluten-free diet on quality of life, it's interesting that actually most of the quality of life studies in children have not reported any significant difference in quality of life between children who have both conditions versus those who just have celiac disease or type 1 diabetes only. However, parents of children who have type 1 diabetes and celiac disease report lower social functioning scores for their children and compared to parents of children with type 1 diabetes alone. Parents also report significantly added stress and burden to their daily life at the time of celiac disease diagnosis in their children with type 1 diabetes. So what can patients and families do to try to improve adherence and reduce burden overall in children who have type 1 and celiac disease? What I tell my patients to do is, as best as they can, is to try to plan ahead. For example, you could look at restaurant menus in advance, call ahead to discuss the gluten-free options with the restaurant and the various carbohydrate contents within the foods. It also could be helpful to estimate insulin doses for a particular item on the menu in advance. And this is particularly helpful for teenagers who may be going to dinner with their friends, working with their parents ahead of time to kind of come up with a game plan. Packing your own snacks for outings, travels, and hanging out with friends. And then establishing a support system outside of family members is also very valuable. This may be a best friend, a teacher, or peer groups. And I'm going to end now with just a few resources that I suggest to my patients that may be helpful. This is a website, the MassGeneral for Children website for snack ideas for children with type 1 diabetes and celiac disease. This is the link. There are also various other online platforms, including the diabetieslink.org. This was formerly called the College Diabetes Network and is particularly a network for young adults with diabetes. There is portals here for peer support groups, resources, and various other leadership opportunities for young adults with diabetes. The JDRF also has a platform on their website that will list regionally different peer groups and community groups that may be of interest to people with type 1 diabetes and with type 1 diabetes. And then lastly, the diabeteseducator.org website has a platform for both online and in-person support for people living with diabetes. And many of these platforms, of course, will include patients who have diabetes and celiac disease. Thank you very much.
Thank you, Dr. Vakharia, for that excellent presentation. And our final presentation will be from Sharon Weston. Sharon is a senior clinical nutrition specialist who works in both the GI nutrition as well as the endocrine divisions at Boston Children's Hospital. Sharon received her undergraduate degree in biochemistry from Colgate University and her master's degree in clinical nutrition from Boston University. She's a member of both the BCH celiac team and diabetes team and is the lead dietitian for the Optimal Wellness for Life clinic. Sharon enjoys helping children and their families succeed in using nutrition to meet their specific health needs so that they can feel good and thrive. She enjoys practicing culinary medicine and is active with the BCH Family Food Connections Food Pantry, running the monthly gluten-free cooking classes, which are provided online. Sharon was the recipient of the SHAR USA 2021 grant and the NASPGHAN CP-NP 2022 grant for a cooking-based intervention for food-insecure families with celiac disease to improve access to food, quality of life, and gluten-free dietary adherence. So Sharon, I'd like to invite you to share your screen and share your presentation with us.
Okay. Thank you, Dr. Kelly. All right. And thank you to Dr. Colling and Dr. Vakharia for just leaving the groundwork here to lead into just talking about nutrition concerns and challenges for patients with celiac disease and type 1 diabetes. These are my disclosures. So we know that adhering to the gluten-free diet is the only currently known treatment for celiac disease. And when you add in the diagnosis of type 1 diabetes now, we have to not only think about choosing foods that are gluten-free, but we also need to pay attention to how those foods eat and impact blood glucose levels. So looking at macronutrients, such as carbohydrates, protein, and fat, and understanding how different types of carbohydrates impact blood glucose management plays an important role nutritionally. And as you can see from this sample CGM data or continuous glucose monitoring data, gluten-free foods can impact blood glucose levels in very unexpected ways sometimes, as Dr. Vakharia also talked about. And so this just shows a significant rise after breakfast, and then again after lunch, and then after dinner, and then an overcorrection leads to hypoglycemia later in the evening. This example of a 4-year-old newly diagnosed celiac with celiac disease food record after having also been diagnosed with type 1 diabetes just 2 months earlier indicates a relatively high carbohydrate intake that resulted in hyperglycemia. And so this food record is something that I like to do with my patients, and just looking at the macronutrients meal by meal can be very helpful in understanding why things are happening with blood sugar trends. So just to walk through this briefly, you can see that by looking at these circles that break down our macronutrient composition of each meal, the blue representing carbohydrate, red representing fat, and green representing protein, you can see that in this column here, most of the meals or snacks are over 50%. Oops. Sorry. Let's see if we can get back to that. There we go. Over 50% carbohydrate by macronutrients. And so that is going to be something that we talk about later in this presentation, just paying attention to our macronutrients and also the type of carbohydrates that are composed of those. So this is exactly just indicating these different types of food fuels and how they impact our blood glucose level over time. The first circle of food fuel is composed of higher glycemic carbohydrates, and that creates a rapid rise in blood sugar. At the top here is where insulin goes to work, but if you're only consuming high glycemic carbohydrates, you're going to have a rapid drop in blood sugar. When you look at the second circle of food fuel, replacing those high glycemic carbohydrates with things that have more fiber, less sugar, are going to result in a slower rise and more gradual fall in blood sugar after insulin goes to work, a little lower peak as well, but you still have a roller coaster effect. When you look at the third circle of food fuel and you choose one of those lower glycemic carbohydrates and add in a protein or a fat, that results in a more ideal source of fuel to our bodies, where we have a more gradual rise and fall in blood sugar, a lower peak. And that is really more optimal for just blood sugar control. The way I like to explain it to my patients is just, if you think about an experiment where you stick out your tongue and you were to place a refined grain kind of cracker on your tongue, close your mouth for 5 minutes, not allowed to chew, what happens to that cracker 5 minutes later? And the answer is that it starts to dissolve. And even though it doesn't taste sugary, it actually starts to affect our blood sugar more quickly than we would expect. And so that is a high glycemic carbohydrate. Whereas if you did the same experiment with a baby carrot, 5 minutes later, nothing really happens to that carrot because we need to do work to unlock those carbohydrates, chewing, digesting, and that would qualify as a lower glycemic carbohydrate. Whereas something in the middle might be a cracker with whole seeds, and that doesn't quite dissolve like that highly refined grain cracker. It's also very different than the carrot. So we're going to put that in as the moderate glycemic category. And so in general, a low glycemic gluten-free diet is helpful in just controlling our blood glucose levels, where we might see gluten-free foods impacting our blood glucose levels in unexpected ways. And a lower glycemic gluten-free diet is generally a healthy diet. It's going to include minimally processed foods, lean proteins, dairy, nuts and seeds, legumes, non-starchy vegetables, lower glycemic fruits, and whole grains that are gluten-free. And these whole grains, especially in their unrefined form, are an important part of this diet. This study looked at a systematic meta-analysis that reviewed 18 different studies that evaluated gluten-free breads that totaled 132 bread samples. And it was interesting in that the results showed that over 60% of the samples presented with high glycemic indexes, whereas only 18% were classified as low glycemic. And so when you're paying attention to looking at the food labels for different grains that are gluten-free, looking at the ingredients and noticing things like almond flour or flaxseed flour that have more protein or fat or more fiber are going to be better at helping maintain that blood glucose level. Whereas if you see in the ingredients things like white rice flour or corn flour, those higher glycemic ingredients are going to be more troublemakers with that rapid rise in blood sugar. This study also looked at the ingredients in terms of additional ingredients and found that things like pectins and gums and protein were going to help lower that glycemic index or that glycemic response in those breads. So things that included fiber, yogurt, cottage cheese or curd cheese, sourdough, psyllium, hydrocolloids, enzymes, fructans, and resistant starch all were helpful in lowering the glycemic response. This table looks at different carbohydrates and it categorizes them into high glycemic, moderate glycemic, or low glycemic carbohydrates. And it's helpful to just understand what falls in which category. So first off, we always want to make sure that we're choosing labeled gluten-free grains in terms of bread, cereals, bars, and so that we're always making sure that we're checking our labels for especially also things like snacks and sweets. But walking through this in vegetables, things that would fall into the higher glycemic category would be things from white potatoes, whereas in the moderate would be more things like sweet potatoes or peas or squash. And then in the low glycemic category would be things like our non-starchy vegetables, broccoli, carrots, tomatoes. In the fruit section, things in the high glycemic category would include juice, fruits that are canned in syrup. Moderate glycemic would be things like processed fruit, like applesauce, or tropical fruits like pineapple. And then low glycemic fruits would include berries, apples, oranges, melon. In the bean section, all legumes are low glycemic except for baked beans because of the sugar in the sauce. Under the grains section, high glycemic grains are going to be things that are more refined or have added sugar that in general is more than 6 grams per serving. So white rice would fall into that category for high glycemic, or sugary cereals. In the moderate glycemic category for grains, that's going to include things that have more fiber, less sugar, so brown rice or quinoa, for example. And then in our snacks and sweets, those are all of our chips and cookies, and also sugar sweetened beverages. We also want to talk about our proteins and fats. And so paying attention to high glycemic proteins, which would include things that are more highly processed, things like gluten-free chicken nuggets, or things that have added sugar, like chocolate milk, or yogurts with more than 8 grams of sugar per serving. And then under our fat category, these are all important things to include in our meals to just create that balance of glycemic rise. So the main messages are really thinking about eating gluten-free balanced meals, choosing gluten-free paired snacks, and including a variety of foods. Also being aware that protein and fat will impact blood glucose levels, as well as different varieties of gluten-free grains, depending on the ingredients, and fiber additives and gums, and also extra protein may also impact blood glucose levels. The gluten-free balanced plate model is an easy visual to help with meal planning. And so I like to just think about it in steps. So step 1, choose your fruit or vegetable. Step 2, pick your carbohydrate. Step 3, your protein. And step 4, your fat. And it doesn't have to be complicated to create a balanced meal. So this is very helpful for busy families that are managing school schedules and multiple siblings. And so just planning ahead, planning meals and planning snacks ahead can be a real key element to success, and also just minimize frustration. And some families have members that are not all required to follow a gluten-free diet. So they may choose to go 100% gluten-free or not. And that's the family's choice. But we always talk about trying to prepare the gluten-free meal recipes first, and then follow it in the kitchen by cooking the non-gluten-free recipe second, just to minimize that cross-contamination. And again, taking advantage of naturally gluten-free foods, taking advantage of batch cooking, and just keeping things simple can really reduce stress. This chart also just focuses on paired snacks, which I think are really important to help with glycemic control. And paired snacks really provide the fuel to our bodies that provides a more gradual rise and fall in blood sugar. And I also just encourage eating mindfully when snacking, just to slow things down a little. But this just combines something from the first column, which is a low or moderate glycemic carbohydrate, and it pairs it with something from the second column that provides either a protein or a fat. So for example, it could be an apple and a piece of cheese. It could be 2 clementines and some Greek yogurt, and those all create nice, balanced, paired snacks. It's also important to think about strategies for insulin coverage with the combination of type 1 and celiac disease. And so when you're using new foods that you're not used to going on a gluten-free diet, it is important to pay attention to different amounts of protein or fat that might be in that gluten-free food, different types of glycemic response grains that might be in that gluten-free food. And so thinking about modifying the mode of delivery of your insulin, if you have a pump, can also help with the insulin coverage. So partially covering protein or fat by providing a dual wave type of insulin administration can help. And working with your endocrine team to modify your insulin delivery options is very important. So again, encouraging families to take advantage of all the naturally gluten-free foods that are out there is really helpful for tips to success, especially just minimizing frustration. And so fruits and vegetables and meat and poultry and fish, milk, yogurt, cheese, nuts and seeds and nut butters, and gluten-free whole grains is very important to just, make it simple. These are not only wholesome food choices, but they tend to be lower in glycemic index, and they can help to moderate those blood glucose increases. Choosing less highly processed carbohydrates, and even if they're gluten-free, will help to decrease the intake of those fast-acting carbohydrates. It'll increase fiber and just also increase nutritional quality. And then just again, batch cooking is something I also really encourage with families. So instead of making just one batch, make a double batch and then freeze half of it so that you can just take it out of the freezer, and it can be very quick and easy when things are busy. So again, keeping things simple. I also just want to briefly talk about a 504 plan for our school-age children. A 504 is important because it is a legally binding document that's created by the parent and the school, either public or a charter school, and it sets out the actions that the school will take to make sure that the student with celiac disease and type 1 diabetes is medically safe and has the same access to education as other children and is treated fairly. And so this is a little different than a health plan, which is not legally binding, but this can really be helpful for a lot of different things that come up at school. And also just working with your school food service and educating them, not only the school food service director, but also the school nurse on just the importance of nutrition, different macronutrients and how they affect blood sugar, different ways to prepare balanced meals and paired snacks can really lead to success. So this example right here of this picture was a picture that one of my patients' moms sent me on a school trip that the child was going on. And so it included a gluten-free bagel, gluten-free sugary cereal, gluten-free sugary yogurt, juice, and dried fruit and water. So that was such a large amount of high glycemic carbohydrates with minimal protein or healthy fats that you can see from the CGM data there created a rapid rise in blood sugar that then required a correction that didn't really need to happen if a more appropriate meal was provided. And finally, just touching on the fact that we have a dual diagnosis class at Boston Children's Hospital. This is a monthly virtual group class that we provide to newly diagnosed celiac patients that have type 1 diabetes. And we find that it's been really helpful. It just addresses a lot of specific questions that participants have as they switch to a gluten-free diet. And we talk a lot about strategies for optimizing blood glucose control and just leading to success. And then I've just included some resources here.
Sorry, I think I was muted. I was just thanking all three of our presenters, including Sharon, for excellent presentations. They were highly relevant, comprehensive, and very easy to follow. So thank you very much indeed. And now we have some time for some questions for our panelists. So let me begin with a question from one of our participants who asks, what are the factors that alter blood sugars and cause swings in blood sugar levels in patients with celiac disease? So that's open to all of our panelists.
Well, thank you for that question. As I mentioned in my talk, there are several factors actually in children and adults with type 1 diabetes and celiac disease that can affect glycemic regulation. The one major one that is the malabsorption component. And we all, I think, slightly touched on that a bit. And so there's unpredictable absorption of nutrition, some of which is carbohydrates. And because our dosing for insulin for type 1 diabetes is heavily influenced by carbohydrate intake, that can certainly affect glycemic control. Dr. Colling had answered a similar question in the chat if you want to take a look. And there are other factors that can also contribute to glycemic variation in type 1 diabetes and celiac, including the timing of insulin. Not only is malabsorption a component, but because the absorption of food, generally speaking, in children who have undiagnosed or uncontrolled celiac disease versus not, the way that the food gets absorbed, the timing of food absorption can also impact the way that insulin sort of appropriately works with the food absorption. And so you can get some glycemic variability there as well.
Dr. Colling or Sharon, any additional comments? No. Okay. Very good. Second question, some questions on terminology, in fact. There's a question as what is autoimmune diabetes? Is that different to type 1 or different to type 2? Is it a third form of diabetes mellitus?
I think there was also a question in the chat related to type 1.5 diabetes. So I think that's a great question. It's a common area of confusion. So type 1 diabetes is a term that's often used for as equivalent as LADA, so latent autoimmune diabetes in the adult. And really, type 1 diabetes is autoimmune diabetes. LADA is an autoimmune diabetes. It's a spectrum of loss of insulin. And in some individuals, and many studies now are really considering this type 1.5 diabetes a subset of type 1 rather than a distinct entity, because they're both really characterized by insulin loss and damage to the pancreatic beta cell. So the terminology is confusing. It confuses clinicians as well. So, and I'm sure that if you're seeing several different doctors, they may use the words differently, but it really is capturing what had historically been a different presentation of the destruction of the beta cell in adults presenting with a type 1-like form of diabetes rather than a totally different disease.
Very good. Thank you. Another terminology question. Hemoglobin A1C came up several times in the presentations. What is hemoglobin A1C?
So hemoglobin A1C is a lab test. It's a blood test that's performed, and it's an estimate of the average blood sugar over the past 90 days. And it's one of the ways that diabetes can be diagnosed. So and a value of 6.5% or greater is diagnostic of diabetes. And so we should have clarified that. So thank you for asking.
Thank you. A question about screening for type 1 diabetes in celiac disease. The American Diabetic Association recommendation was to screen only if there were signs, symptoms, or lab values to suggest. But knowing that celiac disease is often relatively silent, why is screening not recommended for everybody?
So is the question, just to clarify, is the question screening for type 1 diabetes in someone who has celiac disease, or the opposite, screening for celiac? Okay.
I'm sorry, I may have fumbled it. It's screening for celiac disease in patients with type 1 diabetes.
Okay. Yeah. And so the guidelines do differ between pediatric patients and adult patients, as Dr. Colling and I had said. So, of course, you want to screen anytime there are symptoms that are indicative of concern for celiac disease. And so that should occur. In the pediatric population, there are clear guidelines that say that screening should take place at the time of diabetes diagnosis, 2 years after onset, and then 5 years after onset of diabetes. However, the interval of screening beyond 5 years of diabetes onset, at least in the pediatric population, there's insufficient data to really recommend whether they should be screened annually or just based on symptoms. And in clinical practice, I would say providers have a mixture of what they do. In the pediatric population, in the pediatric clinics, many pediatric endocrinologists will continue to screen every 1 to 2 years, even beyond 5 years of their diabetes onset for celiac disease, until essentially they've transitioned to the adult clinics. And I would say practice in the adult clinics often tends to be more related to symptom-based screening.
Very good. A question that was directed to Sharon, which is, what is the status of diet soda use in patients with diabetes? Is it good or bad?
I always encourage using water instead, but there are times when water is not well accepted by children. And so we try to take like a step-by-step process where we just move gradually from diet soda towards sparkling water instead, and maybe flavor it with natural flavors. So diet soda is not going to provide the sugar that regular soda does, but the chemicals in there are not the healthiest thing for us. And also there are some theories that that sugary taste still fools our brain into thinking that some sugar is coming and then it doesn't, and then it makes us eat more. So, so we always really try to encourage plain milk, sparkling water, and just try our best to flavor it with just natural ways.
Thank you. Any other comments on that? No. Okay. There are several questions along the lines of, can COVID trigger celiac disease, or can COVID trigger type 1 diabetes?
I can try to answer this question, although I think since COVID is a fairly recent disease, it's probably not perfectly answered really for any of the viral infections out there. It's known that viruses are associated and thought to trigger autoimmune conditions, and so it wouldn't be surprising, and in kind of observational studies that's been seen for COVID too. So, you know, I think there are studies that show that children who had COVID had an increased risk of ultimately developing type 1 diabetes compared to those who didn't. I do think it's early to say definitively know the answer, but given what we know about other viruses and kind of the increasing research, which I would defer to Dr. Kelly on, of viruses and celiac disease, it's reasonable. There were also questions about like risk mitigation. And I think that ends up being a very personal choice because you're balancing what may be a very low risk, but slightly increased in either your child or yourself, and balancing kind of what you want when living your life. And so it really has to be an individual decision in terms of how much you're reducing your risk of catching a contagious virus.
Very good. Thank you. We know that there's an increased risk for type 1 diabetes associated with celiac disease. Is there an additional risk for type 2 diabetes in patients with celiac disease?
So that hasn't been demonstrated, that there's an association between type 2 diabetes and celiac disease, the same way that there's the genetic shared risk factors for the type 1 diabetes and celiac disease.
Correct. Question about salt. Is salt consumption strongly associated with insulin resistance or not?
I would say most likely not. But when you think about insulin resistance and excess consumption of carbohydrates and high glycemic carbohydrates, then you know, you're eating larger amounts of typically processed foods that might have a lot of sodium in them, and that just might create a bad cycle. So, but I would say the answer to the question is no.
Okay. Does type 2 diabetes ever develop in adults with celiac disease, or is it mainly a childhood disorder? I'm sorry, type 1 diabetes rather.
Okay, sorry, type 1. Yeah, so yes, it can. Type 1 diabetes can be diagnosed actually throughout the age spectrum, even though it's historically called juvenile diabetes. The one study we showed that the diagnosis of celiac disease often follows diabetes, but that may be complicated by the fact that diabetes is very symptomatic, and then once you have type 1 diabetes, people may be looking for celiac disease. So it's possible. We don't actually know in terms of what came first. So yes, it's absolutely possible.
With that being said, in the adult population, the incidence of type 1 diabetes does progressively decrease over time. And so that being said, you know, basically beyond the age of 45 to 50 years old, the chances of being diagnosed with type 1 diabetes is significantly reduced. It's really a disease of the young adults, and sort of we're now seeing like middle age as well.
Okay. Is there any association between non-celiac gluten sensitivity and diabetes?
I don't know of one. It doesn't mean that it doesn't exist, but I don't think it's been demonstrated definitively. So I'm sorry if that's not a fabulous answer to your question, but I don't know of an association between those.
Yeah, my answer would be exactly the same. As far as we know, there's no association and no increased risk for diabetes associated with non-celiac gluten sensitivity. A question about pediatric management. My grandson has type 1 diabetes since age 5 and was diagnosed with celiac disease at age 10. He hates following the gluten-free diet and doesn't want to comply. How can I support him and his parents on this? So any
that is such a great question, and I'm sure Sharon also has experience with family, in these types of situations. It is challenging, and especially 5-year-old. But what I would say is, as best as you can, two things. One is to try to really partner with the child. If it is, what exactly is it about the gluten-free diet that they dislike? Is it the taste? Is it just the idea? Is it the limited availability, or sort of what is it? And if they could sort of help break down sort of what is the actual barrier there. Suppose it is something like the types of food that are available. What is that child's favorite food? Is there some way that we could work together with the family to come up with a recipe or some other creative idea to make a food that is similar, or the exact type of food, but just in a gluten-free method? And I think kind of taking it, instead of looking at it as a big picture of every single item being gluten-free, if they can at least start with some staple items the child eats very commonly, and really, partnering with the child to, establish the trust and the relationship, and that they can do this, and then slowly kind of introducing it in the broader spectrum to all foods across the board. That's what I would recommend.
And
I agree with Dr. Vakharia. I think that, so the question I think was that it was a 5-year-old that now is 10, but I think that first focusing on all of those foods that are naturally gluten-free. There are so many foods that are gluten-free that you don't even have to think about. So all of your, fruits and vegetables and proteins and dairy, nuts and seeds, like those are all gluten-free, and then really trying to work together with this child and the family to just, again, just find fun recipes, work, do things together. Everybody can try the foods together instead of singling out this child to eat separately or differently than everybody else. And then I think also taking advantage of support groups, so that this child can also associate with peers that follow a gluten-free diet, and you might just find that there is a lot of fun to it. So just, trying to take the positive side.
Excellent. Our time has come to a close. I want to again thank our presenters for really superb presentations. Thank you so much for taking the time to share with us this afternoon. And now I'll turn the stage over back to Lee Graham.
Thank you, Dr. Kelly. I appreciate it. And thank you to our speakers. It was absolutely wonderful. I really appreciate even getting close to this topic. It's terrific and educational and extremely helpful. Our next webinar will be held on April 26th, and it's entitled Gluten-Related Disorders and the Spectrum of Eating Disorders. So until then, from all of us here, we'll see you next time, and please stay well.